Aloha. Thank you for coming today to the third of 4 webinars about the new MedQuest Community Palliative Care Benefit. My name is Jeanette Kojane, and I'm the Executive Director of Kukuamau. Thanks to a grant from Hui Pohala, Kukuamau has organized this series with our wonderful speakers. And a shout out to our teams in the background who are making everything happen. The first 3 webinars of this series are for professionals, and the final is for the public. Please help us spread the word not only about the benefit, but about the webinar series. So today we have 4 speakers: Judy Mohr Peterson, Dr. Curtis Toma, Dr. Jasmin Jensen, and Torrie Fields. After the presentations, there'll be a live Q&A session, so please put any questions you have as we go along into the Q&A, and we'll try to get to as many as we can. Thank you to everyone over the years who has worked on making this benefit a reality and helping us to be the first state in the country to be able to offer this to our people. So mahalo for coming, and we'll start the presentations now.
Hi, I'm Judy Mohr Peterson, MedQuest Administrator in Hawaii. Aloha, and thank you so much for attending this webinar series on the new Medicaid benefit for community palliative care. You know, we all want high quality care for ourselves and our family, especially when we have a serious illness. Unfortunately, we have a fragmented, confusing healthcare system. And the more complex your health and healthcare needs are, the more challenging it is. Navigating the healthcare system to get comprehensive, coordinated care can be extremely difficult. And community palliative care helps fill this gap and is the type of care we need for individuals with serious illness. It provides extra support from a multidisciplinary team that bridges all care settings, geographies, and cultures. It truly represents a whole person approach to care that we all value. For this reason, we at MedQuest recognized the need to make community palliative care a regular part of the Medicaid benefit. With the approval of the federal government, we were able to amend our state plan, and we're very proud to say that Hawaii is the first state in the nation to offer this. We're excited to present further details on community palliative care benefit throughout this webinar series. And on behalf of Hawaii's Quest members, mahalo for your help in making community palliative care more accessible for all of our communities across our islands. Mahalo.
Dr. Curtis Toma completed a combined residency in both internal medicine and pediatrics and served as pediatric chief resident. During his clinical career, he has worked with underserved populations at community health centers in Hawaii. He currently serves as Hawaii's Medicaid MedQuest Medical Director. Thank you, Dr. Toma.
Yeah, thank you, Jeanette, and thank you for joining today's session on palliative care for children, and thank you for serving the Medicaid children in Hawaii. I'm Curtis Toma, Hawaii MedQuest Medical Director. I'm really excited about this new benefit with palliative care, and we'll go over some of the slides to do an overview. So community palliative care is specialized medical care for people living with a serious illness, provides relief from the symptoms and stress of the illness, improves quality of life for both the patient and the family, provided in non-hospital and community settings across the continuum of care, based on the needs of the patient, not on the patient's prognosis. Appropriate at any age and at any stage in a serious illness, and that can be provided along with curative treatment. So the reason why we call it community palliative care is this is the first time we had palliative care in a community setting. Previously, it was just in an inpatient setting. This is probably the most important slide for my section, and we'll start with the bottom where it says concurrent care services. So what is concurrent care services? Concurrent care services is when you provide hospice services by a hospice agency as well as treatment for the patient, as opposed to hospice in general. This is hospice with treatment. So for example, if you had a child on hospice getting chemotherapy or dialysis, and that would be concurrent care services. So that's how a lot of us kind of know hospice for kids, concurrent care services, probably the most common scenario for kids. Now, if you look at this second triangle, community palliative care in the middle, what is that and how is it different from concurrent care services? So community palliative care is different from concurrent care services in a couple ways. The first way is you throw a wider net, you can catch a wider denominator of kids and you can catch kids upstream. So for example, if a child or family is not yet ready for hospice, they can apply for community palliative care. So you can catch kids earlier and you can catch more kids. The other difference is it doesn't have to be, kids don't have to be in hospice and they don't have to be hospice eligible. They can just have community palliative care. So the biggest triangle says early and periodic screening, diagnosis, and treatment, EPSDT. So what is that? And EPSDT is just another phrase for the benefits for Medicaid children. So for Medicaid children, we call their array of benefits EPSDT. So the purpose of this slide is to show that whatever benefits you have from Medicaid, you still have all those benefits, whether or not you have community palliative care or concurrent care, you still have all your other Medicaid benefits. So the next question is, who qualifies for pediatric palliative care and how do we determine eligibility? So number one, you qualify through an assessment to determine eligibility. Number two is you must meet a qualifying condition criteria and one element of functional decline, and we'll go over more detail on both of those. A provider referral can serve as a positive screen for eligibility for authorization by the member's health plan. Health plans may approve other conditions on a case-by-case basis, and MedQuest has specified benchmarks and tools to determine level of function decline needed. So even though we have general qualifying conditions and bars for functional decline, a provider honestly can always put in an application and the questions can review it on a case-by-case basis. But there are general kind of guidelines so you kind of know what's in the ballpark. And there are some conditions for children only that do not need to meet a functional decline bar. But in general, you need to meet a qualifying condition and a functional decline bar unless otherwise specified. The other exclusion criteria is if you're enrolled in hospice or you're enrolled in a solid organ or stem cell transplant, also known as bone marrow transplant, then you're excluded from pediatric palliative care. But otherwise, anyone who meets the qualifying conditions and functional bar can apply for pediatric palliative care. Qualifying condition for children, you must meet a qualifying condition. And what are those qualifying conditions? So the purpose of this slide is to show that the qualifying conditions are much more broad than with hospice. You're looking at conditions that are further upstream. Now, when we say, as an example, renal disease, it doesn't mean every kid with renal disease is qualified for palliative care, but a subset of renal disease broader than hospice, but not all renal disease. So if you want more detail as to what disease is, there's a MedQuest memo posted on the website in Appendix A. It lists further details from these kind of broader topics of some examples. Also, there's a national document called Standards of Practice for Pediatric Palliative Care that was published in 2022 that has a list of examples of qualifying conditions. So the condition will be broader than hospice, but not all conditions. Another bar for pediatric palliative care is functional decline. And there are several different ways to meet functional decline, but we chose two of the topics that are kind of more pertinent to kids, just to give some examples. So one bar for functional decline is acute healthcare utilization. And that bar would be, say, if you had one hospitalization in 12 months, you meet the functional bar. If you had 2 or more ER visits in the past 6 months, you meet the functional bar. Now, you still have to meet the category bar, the diagnosis bar, but these are examples of the functional bar. And the durable medical equipment bar is very flexible. It varies from trach to wheelchair, but if you meet one of these bars, you meet the functional bar. As long as you also meet the category bar, you qualify for palliative care. Covered services. So what do you get when you come on to palliative care? And this is what I'm most excited about, is there's a whole array of support that's available. And some speakers will go over the more detail on this, but care plan development, comprehensive assessments using validated tools aligned with the family and caregiver goals. So this whole kind of assessment and planning is done. And for me, the interdisciplinary team that surrounds the patient is so helpful. And we'll go over that more in the next slide, as well as comprehensive management and care coordination, communication, things like advanced care planning. So there's this whole array of services that you as the individual provider wouldn't have the time and expertise to do, that is added on to the patient care. These are exciting examples of who's on the interdisciplinary team. So there is a physician specializing in palliative care. There's a RN, there's a LCSW, there's a grief counselor. There's even a child life specialist. These are required members of the interdisciplinary care team. So all this talent will surround the patient. In addition, there's also optional members, things like pharmacist, social worker, licensed mental health provider, community health worker, that can be pulled in to add more support. Okay, so that's it for the summary. We're really excited. Hawaii is the first state in the nation to add this Medicaid benefit. We're really excited about it, and looking forward to further collaboration on it. Thank you.
Dr. Jasmin Jensen is a board-certified hospice and palliative care physician and a pediatric oncologist. She has been a member of the medical team at Kapiʻolani Medical Center for over 10 years, providing care for patients with complex, chronic, and often life-limiting conditions. One of her goals has been to increase access to pediatric palliative care and hospice services for patients and families residing on our neighbor islands. She works closely with community-based hospice agencies throughout the state to ensure that kids and families have support in their own communities to help them navigate the unimaginable challenges they face. Thank you, Dr. Jensen.
Thank you, Jeanette, for that wonderful introduction. I'm so excited to be here with you today to talk about this new benefit that has been approved for our community. And I, of course, will be focusing on the pediatric component of the benefit. So moving right along, my agenda today is to share with you the roles of the various team members who make up the pediatric palliative care team. It is a multidisciplinary team, and that's so important to the success of this effort. I am also going to share with you a case study that is fictional, but loosely based on some of the patients that I've cared for in our community. And my hope is that I can again illustrate what the team members on the palliative care team will be providing for these patients and families, will hopefully highlight the importance of good care coordination and communication with multidisciplinary team, all of the providers that are taking care of these medically complex kids, and talk just about a few of the decision points that might arise in the disease as these kids are followed by a program like this. So this is a very simple slide to illustrate, again, the importance of the multidisciplinary team for the pediatric palliative care effort. Everything focuses and centers around the patient and family. So there's multiple disciplines, multiple clinicians involved, including physicians, RN nurse coordinators. We've got social workers, grief counselors, child life specialists who are focusing on psychosocial well-being, spiritual well-being. And then, of course, PCP, the multidisciplinary pediatric teams are always going to be essential to caring for this patient population. Let's take a closer look at the individual members of the pediatric palliative care team, and we'll start with the physician. Physician is going to have a long-term longitudinal relationship with these families, and continuity of care is so essential for the success of this program. Right from the time that the patient is enrolled on community palliative care benefit, the physician is going to start out that relationship by assuring that the patient is eligible. Eligibility can be determined by any MD, but the physician overseeing the pediatric palliative care team is going to keep a really close eye on this during the time that the patient is on the service. They're also going to be routinely screening and talking to families about physical symptoms that the kids might be experiencing, and ensuring that there is a good plan in place to address these physical symptoms to ensure that kids are able to live their best lives. And from there, the physician is also going to be paying attention to the clinical care plan. So they're going to be engaging in longitudinal goals of care discussions with these families. And it's important to know that goals of care are going to change as these kids transition and their disease processes run their course. And so this is an opportunity for the physician to check in routinely to make sure that the plan remains up to date and is as appropriate for the patient, no matter where they are in their disease trajectory. The physician is also there to ensure that the family is receiving and understanding information from the rest of the clinical team. And this is so important to ensure that they are able to make the best decisions that they can for their kids. And then every member of the palliative care team will be participating in care coordination efforts. And this includes the physician. The physician is going to be communicating not only with other physicians, other clinicians, the pediatric subspecialists, but also with the family. And so basically making sure that all parties are on the same page and know what's most important for the patient, for the family, what the options are for caring for these kids. Our next team member is vitally important, and that is our pediatric nurse coordinators. These nurses are going to make the routine visits for these patients and families, and also if something acute comes up, these nurses are also going to be available to help address those needs. We are going to have on-call availability for these patients. The nurses are expert educators, so they make sure that with any changes in the care plan, whether that's medication related or some kind of physical care that the family is being asked to provide, they're available to make sure that the families know exactly what needs to be done and every step that needs to be taken for those tasks. And then they're also going to help with the interdisciplinary and interagency care coordination, which again is super important because often there's multiple agencies involved with the medical care that these kids are receiving. I can't say enough about our nurses. There's so much that they are tasked with every day, and they do this with such grace and skill. They anticipate problems. They help prevent problems in the home. They're present to hear whatever it is the families are thinking about or trying to process. And they offer our patients and families hope that they can live their best lives at home where they want to be. The psychosocial team is also critical for the success of the palliative care effort. There's multiple team members that make up this team. So thinking about this from a pediatric standpoint, social workers, licensed social workers are going to be part of this benefit. They're going to help assess for psychosocial issues. They're going to connect families to community resources. They're a person who's trained to listen. So they help families with problem solving. And the time that is spent just talking through these issues often does lead to clarity for a lot of them. There will be grief counselors who are part of these teams, and their presence on the team is to make sure that we're not neglecting issues such as spiritual and existential distress that comes inevitably when families are faced with such difficult situations that involve their kids, the most vulnerable member of the family. Most of these families are going to struggle with grief that's triggered by the loss of normalcy. Right after a family receives one of these major diagnoses, it's a huge change. There's so many transitions that need to be made. And then for diagnoses that are life-limiting, grief starts early. And so our grief counselors are here to help families process through anticipatory grief. And for my teams, the patient themselves are young, they're kids. And so we are going to have pediatric patients who are in multiple developmental stages. And so our child life specialists are there to help make sure that we are providing developmentally appropriate care. I kind of think of child life specialists as interpreters for doctors. They explain things in a way that will make sense to kids at their various developmental stages. a lot of these kids are still receiving medical therapies that can be overwhelming and scary. And so the child life specialists help kids to prepare and process that. They do a lot of therapeutic play in anticipation of some of the procedures and the interventions that might be anticipated in the patient's future. And that can go a long way to making medical care more palatable, more reasonable for a young person. And then these kids also have siblings, and siblings are also having to cope and understand these difficult situations. And so the child life specialist is also there to make sure that we are providing these siblings with the care and support that they need. So in order to really help bring this to life, I'm going to share a case presentation. Adam's story is fictional, but it is based on several of the patients that I've cared for here in our community. So just to introduce you to one of our patients, Adam is a healthy, happy baby boy. When he's born, everything seems perfect. He is a joy to his family. At first, he seems to be meeting all of his milestones with no issues. He learns to crawl, he learns to walk, he talks and is very interactive, very loving with his family. Early on, though, Adam's mom becomes somewhat concerned. Adam has a big sister, and she, like all parents, has paid careful attention to both of the development of both of her kids. And she notices that Adam's development is slower than what his sister's was at the same age. She brings us up to the pediatrician at one of his child checks. And at that time, everything still seems okay. The pediatrician reassures her that kids develop at different rates and that Adam's going to be a little different than his sister, and that's okay. On this morning, when Adam walked around the house, his mom felt like he looked like he was drunk. And so that prompts another trip to the pediatrician, and he agrees that Adam's exam is not normal now, and he recommends that Adam be admitted to the hospital. Right off the bat, after this admission, an MRI is obtained, and it's not normal, but they don't know why. They're not able to give a diagnosis immediately. So think about what this would be like if you were in these parents' shoes. All of a sudden, your world that seems so normal seems so uncertain, and there's so many questions that are going through these parents' minds. There's also so much emotion, fear of what might come, hope that this is something that's going to get better. It's just these moments are very heavy when things like this happen. So Adam actually gets discharged without a diagnosis, but that doesn't last for long. He's readmitted a few months later after experiencing a seizure. This is his first seizure, and it lasts for greater than 30 minutes. By that time, genetic testing that had been obtained on the first hospitalization is finally back, and we know now that Adam has a condition called metachromatic leukodystrophy. Treatments are evolving for these conditions, but it's still a very significant subset of kids that have this condition where we don't have good treatment options, and it is a life-limiting condition. During this admission that is happening for seizure control, the decision is made to introduce Adam's family to the inpatient palliative care team at the medical center. Adam's PCP has known the family for a long time, and he's been following closely during this hospital stay. He's noticed that since the first hospital stay, that Adam's parents really have been struggling. They missed some of the follow-up appointments with the specialists that they missed during the first hospital admission. And there's increasing discord between mom and dad. And a lot of team members have brought up that they feel like parents are not on the same page when it comes to Adam's care. The PCP is concerned about discharge and what's going to happen next. And so he reaches out and talks to the inpatient palliative care team about his concerns and asks for advice. Together, the PCP and the palliative care team advised that a palliative care assessment be performed prior to discharge. And this, again, is something that can be done in an inpatient setting, in an outpatient setting, by any medical provider that's caring for Adam. But in many cases, in pediatrics, this is exactly the scenario that we run into. And so it does make sense that this is performed in context with the care that's happening there at this moment of crisis. After this assessment, it's determined that Adam is eligible for community palliative care benefit. Eligibility for this benefit is very inclusive. There's a long list of conditions that you can refer to as far as eligibility. And if there's ever any question, you can always reach out to palliative care groups such as the one that I'm with at Kapiʻolani Medical Center, and we can help to clarify whether or not patients are eligible for these services. If you suspect they are, we would just say, don't hesitate to ask. We want to make sure that patients are connected with services as soon as possible so that families can get the support that they need to deal with situations like what Adam's dealing with. The Community Palliative Care Agency works with the family and providers before discharge, and they quickly develop a plan to support Adam and his family as they learn to navigate life with this new and horrible diagnosis. And just as a reminder of who makes up the palliative care team, we have our circle slide again. So we've got all of our clinical care team as well as psychosocial care team. Of course, the PCP and the multidisciplinary subspecialists are still part of the team and always will be. And at the center of that is Adam and his family. So as far as treatment plan goes, initially, often the psychosocial parts of the treatment plan are vitally important. So the PCP had reached out to the palliative care team in the hospital because he was worried about the psychosocial stress that the parents were experiencing. And so a full assessment is performed. This goes through topics such as financial resources, navigating insurance and disability benefits. Adam's 3, he's going to be going to school soon. And so what is that going to look like? Is that even going to be possible? If parents are dealing with potential mental health issues or just difficulty coping with such extreme stress, referrals can be made so that the parents can access resources for counseling and mental health care. And then connecting families with community support groups so that they can, if they choose, connect with other parents and see how they've handled similar situations. It's not something every family opts to do early on after a diagnosis, but for some parents, it is a very helpful resource to talk to others who've been in similar situations. So our child life specialist is also going to get involved very early. So like I mentioned before, Adam has an older sister, and she's now been through 2 hospitalizations where her baby brother has been very sick. She's old enough to understand that something's not right. And so sibling support needs to happen soon to help her deal with her feelings, make sure that she understands the situation that the family is facing. Adam's only 3, but he does have awareness of what's happening around him. And so again, that developmentally appropriate care, providing developmentally appropriate activities to help him cope with the medical care that he is going to need is something that needs to be addressed. Early on, our grief counselor is going to start to get to know the family, and they're going to ask big questions that are sometimes hard to put into words. What gives Adam's life meaning? What does quality of life mean for this family, for this child? The palliative care physician is going to make sure that Adam's parents understand the information that they received that second hospitalization. Chances are they've never heard of this disease. It's rare. It's something that most families will never encounter. The palliative care doctor is there to make sure that their questions have been answered, that they have the medical information they need to take the next step forward. That doctor is also going to assess symptom burden. This is a condition that can cause numerous physical symptoms, and that symptom burden changes over time as the disease progresses along its trajectory. So the plan for managing physical symptoms needs to start early, and it needs to be updated regularly in order to make sure that Adam is able to live his best life. Even though this family is dealing with a lot of stress, the palliative care physician is going to introduce the topic of advanced care planning. Not so much because we expect the family to be able to make some of these difficult decisions with one of those early meetings, but because that conversation needs to start, it needs to be ongoing. This is a situation where goals of care are likely to change over time as Adam's physical condition changes. So moving forward, Adam and his family is supported by their palliative care team. Visits happen when Adam and his family need them. The palliative care team will continue to manage Adam's symptom control plan to make sure that he can live his best life and be a child to the greatest extent possible. The palliative care team is also going to continue to closely coordinate with the various subspecialists involved, including physiatry and neurology, for issues that come up with his condition, which can include anything from pain and spasticity to breakthrough seizures. Adam's family receives guidance and support when they need to make difficult decisions, and their other specialists are involved every step of the way. So, in summary, this new community palliative care benefit is going to support our complex pediatric patients and their families in innumerable ways. It's a fantastic resource and something that's unique to Hawaii and is so exciting to bring to our community. The palliative care benefit is going to provide a resource that will integrate with and work very closely with the existing care teams and providers. There's going to be enhanced communication and coordination for the care that these complex kids require. We're just getting started with this, so it's a new benefit. We're all learning together, and by working closely together and communicating frequently, we're going to figure out how to maximize this benefit can bring to our patients and to their families. If there's ever any questions about eligibility or programs that patients may or may not be eligible for, I encourage you to reach out to the pediatric palliative care team at Kapiʻolani. We are here to help you navigate through that, and we look forward to working with you. Thank you for letting me talk about this topic. I appreciate the time.
So our next speaker is Torrie Fields, who's the CEO of TFA Analytics, and she has been instrumental in the creation of this benefit and is now working on implementation. Torrie serves as a strategic advisor to the Center to Advance Palliative Care, or CAPC, the Coalition to Transform Advanced Care, CTAC, and the Hawaii Department of Human Services MedQuest Division. Thank you, Torrie.
Thanks, Jeanette. I am here today to share a little bit about the provider contracting requirements, the minimum visits, and the reimbursement and billing codes for the new community palliative care benefit. And this will be specifically for children. Now, one thing to point out before we get started is that a lot of the provider contracting requirements and the billing and coding are the same for adults and kids. So along the way, I will identify those things that are specifically meant for children and go into those in a little bit more detail. So let's start with the provider contracting requirements. First, in the implementation memo, it shares a lot of information about the interdisciplinary team and how teams might be able to come together to deliver community palliative care. You must have at least one employed prescribing clinician, someone who is employed working for your organization in order to get reimbursed for the palliative care benefit. One of those prescribing clinicians who are either contracted or employed with your organization needs to have a specialty certification in hospice or palliative care. So that could be a doctor with board certification in palliative medicine, or it could also be an NP who has certification in palliative care, but they need to be a prescriber. At least one physician needs to be on the team, and the role of that physician would be both delivering direct care and providing program oversight. So even if you have NPs on your team, there will still need to be one physician on the team that you're either employing or contracting with. Palliative care providers must have an interdisciplinary team in place that include all of the required team members documented on the implementation memo. We anticipate that not all members of the interdisciplinary team are going to be employed by the same organization. And so you are able to contract with some of the required members of the team. For all of the members of the interdisciplinary team, either required or optional, you need to have a training plan in place that includes the services required under the benefit, pain and symptom management, care coordination, goals of care, things like that, for all of your employed and contracted staff. That allows us to ensure that palliative care is being provided at the level of specialty that we would anticipate or want for people with serious illness. Every member of the interdisciplinary team who can must be registered with HOKU as a Medicaid provider. So even though the billing is going to go toward the full interdisciplinary team, all of the individual team members on that team need to register with HOKU. For social workers, every team is required to have a licensed clinical social worker, either contracted or employed, to be a palliative care provider. LCSWs play a couple of different roles. One is in delivering some of the mental health components or behavioral health components of the benefit, but also in overseeing other social workers who might do resource management or care coordination, like MSWs or even child life specialists. Other required and optional members of the team can be contracted or employed, and they are not required to be full-time or required to just be a Quest provider. One of the great features of this benefit is also this standalone palliative care assessment. And any billing clinician who is able to bill Quest can be reimbursed for that palliative care assessment. And I'll go into that in a minute or two. All providers reimbursed by the benefit must also have a contract with the health plan to provide community palliative care services. So while any billing clinician can be reimbursed for a palliative care assessment, those who are billing under the bundled payment will need to have a contract with Quest for those services and to go through the process of demonstrating that all of these requirements are met in order to have a contract. So let's talk a little bit about the frequency of services that are expected under this benefit to be delivered through the interdisciplinary team. Interdisciplinary teams are required to be available or accessible 24/7 every day of the year. And that is because people with serious illness often have pain or other symptoms in 9 to 5 hours. And so we want to make sure that palliative care teams are available either via in-person visits or via telemedicine. On at least a quarterly basis, there needs to be an in-person visit by the prescribing clinician. And that's to really make sure that the care plan is being addressed, that pain or other symptoms are being addressed in a timely way, and that the prescribing clinician can reassess the member or the patient. Monthly, there needs to be a visit by the interdisciplinary team. So any member of the required interdisciplinary team or the prescribing clinician need to visit that patient. And that's both to make sure that their pain and other symptoms are being addressed, their care coordination needs are being met, and that there's actually engagement between the palliative care team and the patient. Every other week or biweekly, it is expected that the interdisciplinary team meets to review the patient case, to make sure that the care plan is being managed, and to review patient eligibility. Quarterly, it is expected that the palliative care provider team and the health plan care coordination team actually meet to ensure that any of the care coordination needs that the palliative care provider has are being met and that patient needs are being put at the center of care. At the start, so upon enrollment, palliative care provider teams have 4 weeks to complete a comprehensive interdisciplinary assessment and the development of a care plan for anyone who's accessing the palliative care benefit. And every 6 months or more frequently, it is required that a reassessment be completed so that the care plan can stay up to date and the care team has a better understanding or the best understanding of how to take care of this patient. Now, this is a service or a benefit that is really based on the patient and their care plan and their needs. And so we anticipate that people receiving palliative care services are going to have different amounts of visits or different types of services delivered to them, either in their home or via telemedicine or in the outpatient setting. And so really focus on that care plan and the person's needs in order to determine the number of visits and services that should be delivered in any given month. So how does all of this get reimbursed and paid for? To start, there are 3 different aspects of the bundled payment structure for the palliative care benefit. There's an assessment, a bundled payment, and a reassessment. And assessments and bundled payments are reimbursed to the provider, the palliative care provider. And as I shared previously, any billing clinician can be paid for the assessment. The bundled payment is actually for the interdisciplinary team who's delivering the palliative care services. And we anticipate that the palliative care teams will be the ones performing the reassessment. You see the CPT codes or the HCPC codes that are associated with each portion of this payment structure, and the descriptions for each one of those codes underneath the codes. For providers who are billing on a facility type of claim or a CMS 1450, you will need to use the revenue code associated with palliative care services in combination with the HCPCs in order to get reimbursed. So let's go a little bit deeper into each one of these sections. Starting with the assessment, any billing clinician can be reimbursed for a palliative care assessment. That allows primary care providers, specialists, and palliative care providers to all be on the same page about patient eligibility and the care plan that needs to be documented. All members must be assessed for eligibility and submit documentation for authorization by the provider billing for the bundled payment. So sometimes it is anticipated that primary care providers might bill for the assessment and then refer to a palliative care team who then might bill for the bundle. And so the benefit has been configured in that way. There is a specific HCPC code that you will use for the initial assessment for palliative care services. And again, on the CMS 1500, you'll just bill using the S0280 code. For those that are billing on a CMS 1450, you would bill the HCPC code, this S0280, in combination with the revenue code 0693, so that you can ensure that it's documented that this is for palliative care services. So you'll see that in the table at the bottom. This code or combination of codes can only be billed once per member per provider for each unique episode of care. And so you would anticipate this to be the start of an episode. Providers who are performing the assessment must demonstrate that the member meets eligibility criteria and has consented to receiving services in order for it to be a referral for the bundled payment part of the benefit for the palliative care services. For the assessment, you will need to document the diagnosis code Z51.5 to also demonstrate that this is a palliative care encounter. The Z51.5 does not need to be the primary diagnosis on the claim. It just needs to be documented anywhere on the claim. So once you've assessed the person for palliative care need, you will then start billing for the bundled payment code. and all associated services delivered by the palliative care team will be reimbursed through that monthly bundled payment code. You'll see the HCPC S0311 that is specifically a monthly bundled payment rate for advanced illness management. And for those billing on a 1450, you'll use the revenue code 0690 to say that that's palliative care services. Providers cannot be reimbursed more than one time per month for services, and you must deliver services by the interdisciplinary team during that month in order to be reimbursed. And this is not something that's prorated. So providers can be reimbursed in full for each month that somebody is enrolled and receiving services. And because this is a bundled payment, providers delivering care must not bill for additional services that would be included as part of the bundled payment rate. You can look in the appendix section of the implementation memo to look at the codes that are associated with that bundled payment. At least once every 6 months, or when somebody's status changes, you will bill a reassessment. And that HCPC code is S0281. So very similar to the assessment, that assessment is going to be ensuring that the care plan is updated and maintained. And you will use that same revenue code if you're a facility, the 0693, to document that this is for palliative care services. Reassessments cannot be reimbursed more than one time per month, but they must be completed at least every 6 months or when somebody's goals for care change. And similar to the assessment, you will want to put the Z51.5 diagnosis code to demonstrate that this is a palliative care encounter. So just some final highlights for you. Only the assessment and the reassessment codes need to have a diagnosis code that specifies that this is a palliative care encounter. Providers who are billing on a CMS 1450 will need to use specified revenue codes in addition to the HCPC code. Codes that are included in the bundled payment differ between Medicaid and dual eligible members, and you will find a comprehensive list of those codes in the implementation memo in the appendix. And for services that are not covered by the codes included in the bundled payment, providers may bill separately. And this can often happen with LCSWs who have an independent practice, or for physicians who might be having palliative care consultations as well. That's a little bit about the contracting standards, the minimum services, and the reimbursement. And I'll turn it over to you, Jeanette.
Well, thank you very much. Thank you to our speakers. We have about 10 minutes for questions, and so I'll just get right into it. I'm going to start with the questions about the form. The 2 questions. UB04 is a hospice billing form. Why would we use this when we have a 1500 claim? And then, are the plans able to accept both 1500 and UB40? Could it be standardized?
We tried to make this as simple as possible to fit into the workflow for any of the provider organizations who are delivering palliative care services. And so there are 2 claims forms, as one of the questioners wrote in. There's the CMS 1500 and the CMS 1450, otherwise known as the UB04. The billing codes work for both of them, so choose the one that works best for you. And the health plans are able to accept both types of claim forms. So if you're a hospice organization that does not have a Medicare Part B practice or a group entity, then you can use the CMS 1450 standard to what you have been doing. And if you are set up as a medical group practice, I would encourage you to use the CMS 1500.
Great. So there were some questions where we know the answer is in the memo. So just encouraging people to go to the memo and check those details out. Go back to the beginning of the questions. Are pediatric palliative care benefits available for people under 21, or what is the age cutoff?
The age cutoff is 21. Is that correct, Curtis?
That's correct. So under 21, yeah.
Under 21. Okay. And then what is the pediatric age requirement for the child life specialist services? And I'm wondering, is that also for the family, for the siblings, or?
The requirement is in line with the pediatric piece, right, Jasmin?
Yeah, so there's not an age requirement. The focus there is making sure that somebody is addressing developmentally appropriate needs. And the child life specialist is also there to provide sibling support. So anybody from young infants through young adult can benefit from their involvement.
The next question, there aren't many child life specialists in Hawaii. Any recommendations? So what should we be telling people?
For me, the important part of in the memo there is that child life can be contracted. So it doesn't, I know with the work that I've been doing to get ready for this benefit, we've been exploring options to involve child life that's already established at different organizations, including the medical center. And so the key here is that child life has to be involved in informing the treatment plans. They may not be going out and doing and hands-on doing the activities that are planned to help the kids, but they are there as a resource for the teams so that we do have this component of the care plan taken care of.
Can hospitals refer for the program, and where are referrals sent to?
Absolutely. Hospitals, primary care offices, the subspecialty offices, basically any physician where these kids are encountering clinical care can potentially be referral sources. If there's questions from any of the providers, they can always contact the palliative care team at Kapiʻolani, and we will help you to navigate the eligibility questions. A number of different possibilities as far as organizations and groups that could be delivering the palliative care benefit, but there are some that are already established and have experience through concurrent care for dealing with this patient population and are very comfortable and skilled at dealing with this patient population. So we've got at least one group on every island that is willing to help with the pediatric patient population.
There are a couple questions about the grief counselor, what type of discipline that is. And then, I mean, maybe Torrie, this is for you. Can they be under contract versus hired with the program?
It's a great question. In the memo, what you'll see is a grid that shares what the education and competencies are for that grief counselor. They can definitely be a chaplain or spiritual care professional. And what we're really looking for is somebody who can address somebody's existential suffering and some of their spiritual and other needs associated there. So take a look at the memo and you'll see some pretty well documented educational and skills-based competencies. They are a required member of the team, but you can contract for them. So they do not need to be full-time employed with your organization. They do need to be part of the interdisciplinary team.
Next question is about the IDT. Do all members of the IDT interdisciplinary team, including the child life specialists, need to attend IDT meetings?
All of the required members of the interdisciplinary team need to attend the IDT meetings. So as Jasmin was sharing, one of the really great flexibilities about this benefit is your opportunity or ability to partner. And that means that sometimes the child life specialist, for example, might not actually be doing direct services, but they are there to inform the plan of care. And so you want to include them as part of your interdisciplinary team meetings to ensure that they're informing the plan of care and that they can be part of delivering services if that's what's been identified through the other IDT members.
Okay, next question. Is there a limit to how long patients can get services? Does this run out?
There is no limit to how long somebody can get services. That's actually the focus behind the reassessment codes. So there's a requirement that somebody needs to continue to qualify or continue to have needs that the palliative care team can address. And we don't know necessarily how long that is. It's going to be variable by patient case. So they still need to have needs and qualify for the benefit in order to continue services. And you'll be able to document or get that authorized as part of the reassessment.
I'm going to ask a question about assessment because I know a lot of people are interested in this new piece on assessment and reassessment. Is each member of the palliative care team billing for assessment and reassessment through the bundled payment code only, or can each required palliative care team bill separately for their initial or subsequent assessments if they are able to bill separately?
Good question. The billing clinician or prescribing clinician, what it's likely often an MD or an NP, will perform the initial assessment or the reassessment, and those are billed separately. They're outside of the bundle. All of the members of the interdisciplinary team are contributing to the care plan, and so you'll go through different assessments that will determine, say, somebody's level of spiritual needs or their social needs or their emotional needs, etc. And those will all be covered under the bundled payment. So the bundle is really for the team and what you're doing to address or manage the care plan. And the initial assessment and reassessments will be billed outside of the bundle by a billing clinician.
Yeah, add on to that.
Curtis, please.
For pediatric palliative care, because it's such a unique benefit, palliative care in general is a new topic, right? Not a lot of infrastructure yet. And PEDS is an interesting subset. So I think if providers and, in the community setting, if people are wondering, how do I start this process? How do I do an assessment? I would reach out to Kapiʻolani, because the Children's Hospital actually has a palliative care team. That's the only one I'm aware of to date so far that has the whole kind of team. And then touch base with Jasmin's team and see, like, maybe they'd be willing to do an assessment, see if it's a good candidate or not. But that's what I do early on over.
It's easy for us to get these kids in to be seen, even for the Outer Island patient. I believe that the assessments can be done with telehealth, if I'm not mistaken. So yeah, if it's a patient that we haven't seen in several months, we can update our knowledge, with a telehealth assessment. A lot of times these patients have long records that we can refer to and already have some idea just with a conversation with the providers, and then from there get them scheduled for an assessment in order to make the referral. And we also work really closely with the community agencies that are going to be providing this benefit, and so we can help you to navigate getting those referrals to the right teams.
Unfortunately, we are at time. There were a few more questions, but what we will do is compile all the questions and forward them to MedQuest so questions can be answered moving forward. I really want to thank our speakers for all your time and effort, and also, of course, our participants for coming. Thank you very much to everybody. Thank you for coming, and look forward to working with you on this new benefit. Aloha.